morning. Good morning, everyone, and welcome to our final medical education grand rounds of this academic year. We're delighted to have Dr. John Rich with us. Dr. Rich earned his bachelor's degree in English from Dartmouth, his MD from Duke University School of Medicine, and his master's in public health from the Harvard School of Public Health. He's a professor of health management and policy at Drexel School of Public Health, right across the river. He's also the co-director of the Center for Nonviolence and Justice at Drexel. Dr. Rich's work has focused on issues of urban violence and trauma, health disparities, and on the health of men of color. In 2006, he was granted a MacArthur Foundation Fellowship. In awarding this distinction, the foundation cited his work to design new models of healthcare that stretch across the boundaries of public health, education, social service, and justice systems to engage young men in caring for themselves and their peers. Prior to joining Drexel, Dr. Rich served as the medical director of the Boston Public Health Commission, where he led the city's initiatives on men's health, cancer, cardiovascular health, and health disparities. As a primary care physician at Boston Medical Center, he created the Young Men's Health Clinic and initiated the Boston Health Crew, a program to train inner-city young men as peer health educators. His book about urban violence, titled Wrong Place, Wrong Time, Trauma and Violence in the Lives of Young Black Men, has drawn critical acclaim. And I'm very delighted to say that he has donated his honorarium to supply books for our students, to supply his book for our students. So please join me in welcoming Dr. Rich.
Thank you, Dr. Raboli, for that kind introduction. I want to thank Dean Katz. I want to thank Rachel Burgett for being so gracious and inviting me here today. I'm really honored to be here and impressed by this beautiful facility. I'm impressed by the turnout on the morning after the NCAA finals. I know some of you were up late watching, and so I'm especially honored by your presence here today. I'd like to spend some time this morning talking to you about the issues that affect young people in urban environments, particularly the issue of violence as it affects young black men. And I know that this is an issue of importance. It's on your mind as you see on the day-to-day basis young people who are injured, who live in this city or who live in Philadelphia, and who bear the scars, not only the physical but the psychological scars. You know, I'm reminded that we do our work in a particular context of social justice. And I know that this institution has a particular heart for social justice. And I just want to put this in the context. Those of you who are of my generation will remember that 48 years ago, today, many cities in the United States were up in flames because yesterday marked the 48th anniversary of the killing of Dr. Martin Luther King Jr. And many of us who lived through that time recognize that there was a moment where we went from hope to a sense of despair. We weren't quite sure what the future would hold. But I always go back to that time, and of course many of you who were students here only know that by virtue of history or story. But I always want to keep us in a mind that we're always striving for social justice, and those moments that seemed elusive at that time, or maybe even as though they were slipping away from us, always come back to us coming together, us focusing on the issue at hand. And with the issue of violence, while I know that we sometimes have momentary victories, so violence in Camden, homicides over the past 2 years have decreased. We still see these scourges, and yet there are reasons to be hopeful, and I hope to highlight that today. I would tell you that I come to this work very much as a primary care physician and began understanding the impact of violence and trauma during my time in Boston, when I was training at Boston City Hospital and had taken my first faculty position there. At that time, in the early 90s, we're in the midst of a tremendous epidemic of violence, not only in Boston, but in every major city, owing in large part to the crack epidemic. And almost every day, we would see young people coming through the emergency department. It was tempting in those times to think that we knew why, or to believe that we knew what was happening in the minds and lives of young people. And I thought I knew, to be honest with you. I had a kind of folk sense from watching television what the motivations of young people might be. And I think that as I began to interact with my colleagues and talk about this issue of constant violence, I realized that many of us held in somewhere deep in our brains an unconscious bias about these young people. And the bias was essentially that these young people didn't just get shot, they got themselves shot. There was a tendency to paint with a very broad brush and think about these young people as responsible for their own injuries, a kind of blaming the victim. And when we began to think about the problem of recurrent violence, the logic in our minds, not knowing the lives of these young people, went something like this. Well, this guy's out there doing bad stuff, gets into a fight, gets shot, he comes in, we patch him up, we send him back out, he starts doing more bad stuff, gets shot again, this time he's dead. What's the question, right? But as I began to talk with young people in that setting, I began to realize that their lives were not that simple, nor could we sum them up in that way. That the power of trauma in their lives, the ubiquitous nature of violence in their communities, played a tremendous role. And so, as context, I'd like to just have you compare for 2013 violence in Philadelphia and violence in Boston, where I spent 20 years of my life doing work. And certainly you'll see that in 2013, in Philadelphia, there were 246 homicides, the small blue bar, but there were over 1,100 shootings and almost 8,000 aggravated assaults that were reported to the police. In Boston, smaller city, 40 homicides, 246 shootings reported, and about 2,500 aggravated assaults that were reported to the police. The point I would make is that if we only look at homicides, as is often reported in the newspaper, we dramatically underestimate the impact of violence in communities. And if we think about the fact that these are only the episodes of violence that come to our attention, then we understand that violence is essentially universal for people who live in environments where there's poverty, where there are guns, where there are substances, and where there's tremendous stress. And so these numbers don't count the grandmother who's sitting on her porch, who hears the gunfire a couple of blocks away and wonders if her grandchild has been hit. It doesn't count the little girl who has to walk past the yellow tape and the blood pool on the street on the way to school. We dramatically undercount violence and undercount trauma, but more and more we're beginning to understand the impact that trauma has upon the lives of young people and the risk of chronic disease in the future. So one comparison that often helps us understand the magnitude of this issue is to look at homicide deaths and compare them to war casualties between 2001 and 2010. And what you'll see is that in Afghanistan over that period of time, there were 1,446 war-related casualties. In Philadelphia, there were 3,391 deaths from homicide. And in Iraq, 4,430 war casualties. And so in one American city, just across the river, you see this tremendous toll of violence on a community. Now, if you take, that's just Philadelphia, so if you take all of the major cities in the United States, you see how something's happening that's affecting young people at the most productive part of their lives. It's also, I think, an apt comparison because we know that post-traumatic stress disorder is a consequence of combat exposure, and increasingly we're understanding it as a consequence of urban violence. Now, just to remind you what post-traumatic stress is, it was certainly first, that term was first coined in the aftermath of the Vietnam War, but it's been known for essentially millennia that people returning from combat were not the same people who had departed. It is characterized by hyperarousal or hyperactivity. That is this jumpiness, inability to sleep, the sense of being constantly under threat. This is the kind of symptom that makes people jump when they hear a loud noise, somehow experiencing that as though it were the gunfire that hurt them. Re-experiencing or intrusive symptoms, these are nightmares, flashbacks, body memories that accompany any triggers to the initial injury. Emotional numbing or avoidance. This is the one we don't often talk about, but it's the loss of ability to feel. And often when we're talking with young people who have been victims of violence, and we see this kind of blank face or the flat voice, even when they're talking about something that is that you would think would be quite disturbing, we might interpret that as a lack of connection to how horrible the event was, or sometimes it's interpreted as a kind of lack of remorse, when in fact what we're seeing are the consequences of trauma and post-traumatic stress. And then finally, negative alteration in cognition or mood, the inability to concentrate, or depression and other mood disturbances. You see this on a daily basis as you're interacting with your patients. We don't often think about it in the context of young people who have been victims of violence. And so, to exemplify this, I'd like to share with you a digital story created by a young man who was a victim of urban violence. Dave was shot in Philadelphia and became a client in a program called Healing Hurt People, a hospital-based violence intervention program that I'll describe to you in a few moments. As a part of that program, he participated in a week-long workshop where he identified the story that he wanted to tell and then put images to that. And so what I'd like you to do as you hear this is to listen for any phrases or words that stick with you, that stick in your mind. I'm not asking you to interpret what he's saying, but really just hear what he's saying, his words, and I'm going to ask you just to feed them back to me, anything that sticks with you. Okay? Fair enough? And so this is Dave's digital story.
I was shooting basketball with friends at the playground the first time I saw someone get shot. It was random. I didn't think something like that would happen to me or my family. I have seen a lot. Now I don't sleep at nights. Last year my cousin was killed at home. While everyone is sleeping, I stay awake. I go to sleep in the morning when people are up and moving around. When I do sleep, I have nightmares. Sometimes I wake up crying, feeling lonely, wanting revenge. I wake up paranoid. But there was something that really hurt me, even more than when I got shot 3 times. I was sitting in the street with my brother's head in my lap. Dude stood over him holding a gun before running away. Dude just left. There was nothing I could do. My brother wanted me to hold him. I was crying, panicking. He said, I'm going to be all right. Little did he know, he wasn't. After that, I knew I would get shot. I started imagining how it would be and how I would hold my body so that they wouldn't shoot me in my heart or my head. When walking in the streets, I would think about how to turn my body so that the bullet would hit my shoulders and not my heart, or how I would use my hands and arms to shield my head. I'm always looking back over my shoulder at my own shadow, hoping that one day I will stop focusing on my past, but looking ahead to my future.
So who would just, anything that stuck in your head? Anyone? It's a big room, so I'm just going to ask you to shout it out. Nightmares. Anything else? Say it one more time. Not my heart. Anything? Head in the lap. I knew I'd get shot. Always looking back. Anything else? Future. Revenge. No one in the sandbox is still alive. Great. Awake when others are sleeping. Great. Great. Thank you. Thank you for participating in that way. Those words are powerful because they, I think, express the complexity of feeling in this young person when he's talking about his feelings, his experiences of trauma, and how they relate to issues like revenge, what his life experience has brought him. So to walk you through a few things that continue to stick with us is this idea: none of the people I knew in the sandbox is alive today. So like many people, he has experienced losses over his lifetime, and he traces it really back to those days as a child, that he doesn't really look back at those days, or he looks back fondly with those days, but realizes that those people are gone. He says that his cousin was shot while he was lying in his bed, and he doesn't sleep at night. So the connection between those experiences and his ability to be safe in the world is clear. He says, I have nightmares. I wake up crying, feeling lonely, wanting revenge. And I would think about how we connect those feelings of loss with revenge. I think often there's a tendency to attribute something to these young people that we wouldn't own ourselves, that somehow there's a lust for revenge, but often their feelings, legitimate feelings, whether they act on them or not, are related to the losses that they've experienced. He says, my brother wanted me to hold him. I was crying, panicking. And then after that, I knew I would get shot. Now, as opposed to what I told you, the way that we were thinking about these young people in Boston before I understood what they were experiencing, I might have one particular interpretation of this. But if I take a trauma lens, then I think about these as episodes of trauma. I think about his inability to sleep as a form of hyperarousal. I hear him talking about crying and feeling lonely as depression and more re-experiencing with nightmares. I hear him talk about the loss of his brother as another form of trauma, and this contorting his body into forms to try and prevent himself from getting injured, or having this constantly run through his mind as a form of hyperarousal. And so as I look at his experience through the lens of trauma, I have a different interpretation because I understand what's happening there. What we know now is that for individuals who have suffered a penetrating injury, their risk of recurrence in multiple studies at 5 years is 44%. And that's all comers. That's anyone coming in with a penetrating injury. We know that the 5-year mortality in that group is 20%. And not all of that mortality is due to re-injury. Much of it is due to substance abuse and other problems. And so when we think about the issue of violence, we also need to think about it as a chronic recurrent problem. And many of you who work in settings where you see these young people know that you can see young people coming back again and again. Well, I would ask, what is the relationship between that recurrence and the post-traumatic stress that young people are suffering? Well, we can think about that, I think, as having a relationship, as the trauma as driving the cycle of violence in these young people. It's not only young people in urban environments who are suffering from post-traumatic stress. So in studies done in Boston, at Boston City Hospital, Jane Liebschutz found that 23% of the patients in a primary care practice in an urban setting had diagnosable PTSD. In only 11% of those patients was that recorded in the medical chart. Was there any indication that the provider was aware of it? Among the young people that are seen in Healing Hurt People, almost 75% of them have full-blown PTSD. So we're really seeing something that is more common than not among young people, and yet seldom evaluated and measured. Now, many of you know who are in primary care that there is a screening tool that we can use or should use in primary care to screen for PTSD. It's a 4-item survey that asks about re-experiencing, avoidance, hyperarousal, avoidance, and numbness. This is just as context. Prior to the updating of the diagnosis in the new DSM-5, which includes a new domain, which is alteration of mood or cognition, it will be updated in the future. They're validating a new tool to ensure that it is consistent with those new diagnostic criteria. But it's a pretty easy screen, and if you have if a patient answers yes to 2 of those, I think there's a fair chance that they need further evaluation for PTSD. So even in our day-to-day understanding the impact of post-traumatic stress in primary care patients, I think can take us further in our ability to help patients heal. Certainly, as I said to you, amongst young people who have been victims of violence, the green bar to your right shows 74% meet criteria for PTSD. But even amongst those who do not meet the full criteria, re-experiencing hyperarousal and avoidance are real, and there are disruptive symptoms to the lives of young people. Again, the relationship between violence is that hyperarousal makes you feel constantly unsafe. So how does the cycle of violence play out? So let's say you come in as a victim of violence. You're shot, stabbed, or assaulted. We know that about 80% of people who come into the emergency department with a violent injury will be discharged from the emergency department home. 20% will be admitted. Well, for those young people who I've indicated to you are very likely to have developed symptoms of PTSD, in the acute period, we think about that as acute stress disorder, but the symptoms are essentially the same. They're hyperaroused. They're experiencing nightmares or flashbacks. They're often numb. In that setting, what do young people don't have access to health care? And actually, for many of these young people, no one's explained to them that they may experience these symptoms. And so they think they're going crazy. Well, they turn to what's in their environment to help them sleep. And if you talk with young people who have been victims, a lot of them are using marijuana or alcohol in order to be able to sleep or to calm their nightmares. Well, what's a consequence of using marijuana for a young person in an urban environment, or a young person who is involved with the criminal justice system and who is on probation? Well, you're not getting the job, that's for sure. Your urine's tested at Home Depot or other service types of employment. And so these young people, by virtue of their self-medication, are often cut off from legitimate employment. And if they are on probation, then they're often remanded because they have dirty urines. So once you're cut off from employment, you're often forced into illicit economies if you have few other options, if you don't have the educational background to do other things. On the other hand, if you feel acutely unsafe, we know that young people do not trust the police. We know this from interviews, qualitative work, and other work, but I think all of us know from what has happened over the past 2 years that the documentation, the video documentation of violence at the hands of the police is a clearly confirms for the rest of us what all of these young people knew all along, right? It took video for us to believe that the police were victimizing these young people, often taking their lives. Again, young people knew this for a long time. So if you don't feel safe and you don't trust the police, what do you do if you're hyper-aroused, if you feel like the person who hurt you is still out there? Often young people turn to weapons. And when you turn to a weapon and when you're using substances, your likelihood of jail or death are increased. Now, I'm presenting this as part of work that we did in Boston using qualitative work to understand alternate pathways to re-injury and violence. By offering this, I am not offering an excuse for young people turning to guns or turning to drugs or alcohol, but I am providing an explanation for it. And I think that the notion that people are doing, these young people are doing something that actually has a logic underlying it. They're not crazy. They happen to live in an environment that in many ways is crazy in terms of the violence they're experiencing. So I guess my plea is to understand what is driving this in the lives of young people. And if we talk to patients who come in, I think we'll hear in stark relief exactly how they're approaching this. Now, why is this important more broadly? Why is the issue of trauma more important from a public health perspective? Clearly, if we're going to decrease violence in urban environments, we believe that addressing trauma and post-traumatic stress is critical. But we also now, over the past 20 years, have had accumulating evidence about the impact of early childhood trauma and adversity on chronic disease. And I'd like to spend a few moments on this. How many of you are familiar with the Adverse Childhood Experiences study done in the mid-90s? How many of you would say, good. So it's great that there's some awareness of that. I just want to walk through it for a moment. Two physicians who were doing work in Southern California came to believe that there was a relationship between early childhood adversity and difficulty that women in a weight loss program were having in succeeding in losing weight. And as they surveyed those women, they learned that many of them had suffered sexual victimization in their homes as children. And they began to wonder, how prevalent are adversities in childhood? And what is the impact on other forms of chronic disease? And so they surveyed all of the people in the Kaiser health system at that time, 17,000 people. Most of those people were over the age of 50. Most were college educated. Most were white. And they surveyed them about whether 10 forms of adversity had happened to them prior to the age of 18. They asked about physical, emotional, or sexual abuse, physical or emotional neglect, mental illness in their home, whether they had seen their mother treated violently in the home, whether there was divorce or parental discord, whether a relative had been incarcerated, and whether there was substance abuse in the home. Just those 10 things. They didn't ask about experiences of violence in the street. They didn't ask about discrimination or racism. They didn't ask about violence at the hands of the police. But they asked just about these 10. And they simply gave a score. They didn't even account for how often it had happened to you. If it happened to you once, it was essentially the same as if it had happened to you 100 times. And they assigned a score of 1 if you had any of these happen to you. And some of you here might even look at this and think about, in your life, which of these might have happened to you and what the impact might have been. Well, they were somewhat surprised to find that in that relatively privileged group of people, only 1/3 of those people said that none of those things had happened to them. And about 13% said that 4 or more had occurred to them prior to the age of 18. So that was a shock to these researchers, how common childhood adversity was for this population. More surprising and more profound was the fact that as the number of adversities in childhood increased, so did the risk of negative health outcomes. And it turned out that there was a direct dose-response relationship between childhood adversities and all of the problems you see, all of the problems we care about in public health for that matter. So severe obesity, diabetes, depression, suicide attempts, number of sexually transmitted diseases, number of sexual partners, heart disease, stroke, COPD, as well as smoking, lack of physical activity, alcoholism, drug use, poor work performance. And so they concluded, and many have confirmed, that childhood adversity may be the most powerful predictor of chronic disease that we have. And we know that stress and trauma change the way our bodies work. They alter our hormonal stress response system and creates a wear and tear circumstance on our organs. And so we're seeing how important understanding trauma and stress is not only for young people in urban environments, but for all of us, and especially those who live in settings where there's unrelenting stress, unrelenting poverty. And so to look at young people who have come through Healing Hurt People with regard to adversity in childhood, as I pointed out to you, among the surveyed population in the Adverse Childhood Experiences study, about 13% had 4 or more adversities in childhood. Among young people in Philadelphia who have been victims of violence, that number is 50%. And in the Adverse Childhood Experiences study in California, about 64% of people said that one of those had happened to them, at least one. 100% of the young people we see have had childhood adversity. What then can we do? What can we do as healthcare providers, as people who care about public health and social justice? What is our opportunity? Well, I would first say to you that from my perspective, what was most important was hearing the stories of young people, hearing the stories of our patients, to get a sense of the extent of their lives. We talk a lot about how we develop empathy, both for medical students, health profession students, and others. I firmly believe that my transformation was brought about by understanding and hearing stories, rather than simply using diagnostic tools, because I think that stories help us understand what things mean. And by hearing the stories of our patients, our clients, young people, we understand the world that they live in, and we have an ability to enter in. And so it helps us understand experiences outside of the realm of our own experience, so that we can arrive at explanations, not necessarily excuses, and understand the context in which our patients live. Now I will tell you, I'd heard lots of stories, and I was open. The experience of young people was unlike my own. though I'm an African-American man, as I talked with young African-American men and boys, many of the experiences they had were unlike my own. I was fortunate enough, and I wrote about this in Wrong Place, Wrong Time, to have a young person, in a sense, mentor me, a young man named Roy Martin. And early on in our relationship, I first met Roy when he was in pre-release from state prison for having shot a number of people. He said to me early on, he said, "Your normal is not my normal." That is, if you try and interpret my experience, his experience, he said to me, if you try and understand my experience based on what you think is normal, you're not going to understand it. And therefore, entering into relationships with young people who may be unlike us without the prejudgment that somehow we know their experiences is a powerful tool, not only for their transformation, but for our own. But we can do more than just that. And I want to take a moment to talk to you about Healing Hurt People, a hospital-based violence intervention program that focuses on trauma as the major element of the lives of young people that need to be healed. Developed by my colleague, Dr. Ted Corbin, an emergency medicine physician in Philadelphia, he began to see young people coming through again and again who had been victims of violence and began to understand the extent to which trauma was driving that, and began to reach out to young people to take advantage of this window of opportunity, this vulnerable moment, to not only educate them about what was going to happen to them in their bodies, but also to provide them with a path toward healing. The program is built around a conceptual framework that comes from the sanctuary model developed by Dr. Sandra Bloom and her colleagues. And it puts forth the notion that people who have been traumatized need 4 basic areas to be restored. They need to reestablish safety. They need help managing emotions. Many of those emotions are legitimate emotions of anger, loss, feeling like revenge is appropriate. They need help dealing with loss, and they need to help reestablish a future, because one of the most pernicious effects of trauma is that it cuts off your ability to see the future. In this diagram, if you start at your upper left, a young person comes in with violent injury. They may be admitted, again, 20% admitted, most are discharged, but in that time when they're in the hospital or soon after, someone reaches out to them, a community intervention specialist who's a trained social worker, talks to them, gains their trust, talks to them about what may happen to them in the next few days. You may have nightmares, flashbacks. Don't get a gun, don't smoke a lot of weed if you're feeling unsafe. These symptoms will pass. If they don't, here's what I need you to do. Call me so we can help you. There's an assessment of their safety and an introduction to a longer-term program if that person needs it. Now, not everybody needs that intervention, but they need that brief conversation to help them know that there's someone there who's with them. Some young people will enroll in a 6 to 9 month program where they will have an intense assessment, get intensive case management and navigation through a number of systems that are often quite hostile to these young people. Many of the young people who come in, for example, don't have identification. There's no way you can access any service if you do not have identification. So one of the most fundamental goals is to help these young people get that. There's mentoring, and then there's a very powerful group intervention that focuses on those 4 domains I told you about. Self-groups where young people are guided through seeing their experience through the lens of a trauma framework. They're very powerful, and it's often said that young people won't talk about their feelings in groups. Nothing could be farther from the truth. These young people are hungry to talk about their experiences in a setting that's safe and where they won't be judged. For some of these young people, they'll need more intensive therapy. And for those who have persistent post-traumatic stress, there are a number of strategies, one referenced here called child-family traumatic stress intervention that's an evidence-based intervention with a caregiver and the young person together to address their trauma. Healing Hurt People takes a broad, holistic approach to physical, behavioral, family, and social health in order to help young people heal. The program has had its root at Hahnemann Hospital and St. Christopher's Hospital for Children. Now with support from the Philadelphia Department of Behavioral Health and Intellectual Disability Services, Healing Hurt People is being replicated at Temple, Einstein, and the University of Pennsylvania Penn Presby. The model is to say we'd like to create a citywide effort to create a trauma-informed portal of entry for young people who have been victims of violence. This is unique in the nation because typically violence interventions are funded through law enforcement, sometimes through public health, rarely through behavioral health. And so to take a behavioral health lens to violence, we believe, is an innovation that has the potential to transform how we as healthcare providers think about the problem of violence. In addition to this replication, Dr. Corbin is leading an evaluation that looks at the impact of this trauma-informed intervention across these hospitals. And what's I think unique about this is that while the outcomes include whether the person is re-injured or whether they're arrested, as important are these, do they feel better? How are they in terms of depression, PTSD, substance abuse and alcohol, and sleep quality? It turns out sleep is often a tremendously disrupted phenomenon for these young people, as you heard in David's story. So reestablishing sleep often reestablishes some sense of safety. We'll know more, but the early results are promising in showing a difference between participants in the program and controls that were gathered at those same hospitals. There are across the country perhaps 30 or so hospital-based violence intervention programs, some of which focus specifically on trauma, most of which really focus on case management. So that's one focused intervention in healthcare. We have seen it as our work, though, also to pull together different systems that touch the lives of young people, to ask them to think about the impact of trauma on the young people that they're serving. It turns out that many of these young people are served by multiple systems. And so on a quarterly basis, we convene representatives from the courts, the community, housing, the school district, police, primary care, child protection, leaders in those systems, and we present a case of a young person who's been served by Healing Hurt People. And those systems have the opportunity to talk about where the gaps were in the service to that young person, where the systems that were supposed to help them actually re-traumatize them, so that as a community, we can create what we would call a web of trauma-informed practice. We believe it's our responsibility in public health and medicine to convene across what tend to be siloed systems. There are people there who I think understand the power of healing and how important it is to take that into the community. We continue to be faced, I think, with problems and challenges that we need to take on. I always want to remind us that the issues of firearms as they affect the young people that we see are tremendous. Wherever we sit on the political spectrum about this, we know that there's an opportunity to better understand how the threat of firearms affects communities. As you know, there was a 20-year or so ban on research by the Centers for Disease Control and NIH on firearm injury. It was really a politically enforced ban. About 2 years ago, President Obama issued an executive order lifting that ban, and the Institute of Medicine issued a report on firearm-related research priorities. We have an opportunity in Philadelphia, in Camden, in the region, to engage in scholarship that helps us understand why people turn to firearms. For people who legitimately own firearms, how are they storing those? What is the risk that a child will be injured with a firearm? What is the risk of suicide in homes where firearms are kept? I want to just put that out there because I think there's a tremendous opportunity for scholarship in this area that actually affects how we understand violence, but also what we can do to decrease violence in communities. We're also very much interested in how we engage young people who have been victims of violence in service as community health workers. We have an opportunity to produce a career pathway for young people who have the unique qualifications to serve their peers from a trauma-informed perspective. And we recently were fortunate to get some resources from the Office for Victims of Crime of the Department of Justice to develop a specific curriculum for young people who have been victims to become community health workers. And under the Affordable Care Act, there are provisions that we believe in the future will allow for community health workers to be reimbursed under Medicaid and other insurance. To give you a sense of how powerful that can be, I'd like to introduce you, as I close, to Jermaine. Jermaine is a young man who was a client of Healing Hurt People, who now works alongside us as a peer specialist. This is a complicated story that he'll tell, but it gives you a sense that no matter how complicated these stories are, we have an opportunity. I'd ask you to, again, listen for what strikes you and stays in your mind in Jermaine's story.
Safety is the condition of being safe, freedom from danger, risk, or injury. My definition of safety was being around my friends holding guns. That my definition of safety was about to change. November 23rd, 2011, I was shot while someone was trying to mug me. Being out there every day selling drugs, I knew would eventually get me shot. I just didn't think it would happen how it did. I was walking out of an apartment complex when I saw a shady figure at the entrance to the complex. At that exact moment, I knew my fate. I tried to play it cool by walking past him, but he grabbed my arm, put a gun on my side, and forced me to the back of the apartment complex. Thinking of how to get away, I grappled with the gunman, threw him to the ground, and the gun went off. I was shot 3 times that night. Safety was now a top priority. Having nightmares every night made me feel like I needed to have a gun on me. In my dreams, I would always get shot. The only way I knew how to stay safe was to have a gun and stay around people with guns. Time went on and I was back to the same bad habits, back to the block. Safety was on the brain, so I stopped hustling in the apartment complex. I went to the next safest place, the corner. But being on the corner made me more on edge and put me at greater risk for something to happen to me again. Back then, safety was just having a chance to escape danger. August 30th, 2012, I was shot again on the corner I was hustling on. Not again, I said to myself as I was laying on the ground. I couldn't feel my right leg. The thoughts going through my head were I'd rather die than to be in a wheelchair for the rest of my life. Once in a while, I go back to the spot where I was laying, and I see myself on the ground in pain. I talk to myself that's lying on the ground, shot and bleeding. Trying to comfort myself, I tell myself, you're going to be okay, it's going to be all right. A month in the hospital gave me a lot to think about how I was going to stay safe. I thought the only place I could be safe was the hospital. Today I stay safe by being around people who support me in my future. I stay away from the neighborhood where I was injured. I go to school. I participate in Healing Hurt People program as a client and an intern. I'm making safety decisions that allow me to have a better future. This is what safety means to me now.
So at the end of the day, we believe there's a tremendous opportunity for us as healthcare providers, as public health practitioners, to change the conversation, to create a new narrative about violence, trauma, the relationship between behavioral health and violence. It allows us to be a part of a conversation that in many ways has been abdicated to the criminal justice system. But because we're seeing young people on a daily basis in primary care, in the emergency department, in surgical wards, all across the institution, and in the community, we have an opportunity, I would say even an obligation, to create an opportunity, create a window for change. One way we talk about this is, don't ask what's wrong with me, ask what happened to me. Our opportunity is to move from a notion of either, punishment as our only solution to a notion that individuals and communities can heal and need our help in that. And we need their help because as we hear their stories and as we heal as well, we in a sense become, I would say, more human, more part of the communities that we hope to serve. I just want to acknowledge my colleagues, all of the people who are doing this work in Philadelphia and across the city. I'm grateful for this opportunity to share with you and to hear from you. We're tremendously grateful for the work that you're doing in Camden, and we consider ourselves very much in partnership with you. Thank you for inviting me here today.
Okay.
Thank you so